Good morning, everyone. Welcome to this webinar, how UICC members are responding to the coronavirus pandemic. This is Alessandro here from UICC. I'm just going to pass on the word to our CEO, Cary Adams, who will be chairing this webinar. Welcome to everybody, and thanks for taking the time to joining us today.
Thank you very much, Alessandro, and welcome to everyone who's dialed in. We have a packed meeting today. We can accommodate 100 and we have 100 people dialing in, so thank you very much. And I can assure you this will probably not be the last webinar that we run on this particular subject, given the impact it's having around the world and having on the cancer community. We have an outstanding panel to discuss the issues that coronavirus is creating for us, and they're listed on the screen in front of you, but let me just run through them. We've got Alfredo, who's a senior consultant medical oncologist at the Geneva University's Hospital here in Geneva. We have Pierre Dietrich, who's the chairman of the Department of Oncology at Geneva Universities. I believe he will not be able to join us because we've had, obviously they're quite busy in the hospital at the moment, so Alfredo will be covering the points that he wanted to make. We've also got Dr. Choi from the Cancer Society Center of Korea, and we also have Ulrika Kågström from the Swedish Cancer Society, who is a UICC board member, and we have Mary Wong, who's from the Global Alliance for Chinese Breast Cancer Organizations out there in Hong Kong. So we have a lot of people from around the world dialing in to give you their views and perspective on what is happening on coronavirus in their own part of the world. I will be just facilitating. Please feel free to ask questions. We'll try to pick up as many questions as we can at the end. If we don't answer your question, don't worry about it. I'm sure there are going to be a lot of people who are going to come through with questions for our panelists. So let me start off by welcoming our panelists and move over to our first one, who's Ulrika. Ulrika from the Swedish Cancer Society. Ulrika, perhaps you could let us know what your organization does, and also what's the situation in Sweden at the moment and how is it affecting you?
Well, thank you, and hello everyone. Well, Cancer Fund and Swedish Cancer Society, we're the largest fundraising organization in Sweden. We fund cancer research, we disseminate knowledge about cancer, prevention, treatment and research. We provide cancer patient support through patient organizations and also through a helpline. And we do advocacy, lobbying, decision makers. So we're an independent non-profit organization in Sweden. And we're in a country with 10 million inhabitants. And the whole country is actually now affected by the virus. Around 2,000 people have been confirmed with the virus, but probably somewhere between 30 and 40,000 people are actually affected, and 62 persons have died so far. Upper secondary schools, universities, cinemas, theaters, a lot of shops, most restaurants are closed. Traveling is being restricted, and everyone is recommended to work from home, especially in the major urban areas in the capital, Stockholm. And the financial effects are rapidly building up as many businesses are closing, people are losing their jobs and income. Some of the big industries like Volvo and Scania have laid off tens of thousands of workers. And cancer screening and cancer treatment are being postponed. Field hospitals for intensive care are now being built up in Stockholm and also in Gothenburg, and probably also in the third major urban city of Sweden. And if someone would have told me like 6 months ago, I've visited many field hospitals during armed conflicts and after natural disasters, and if someone would have told me that we would have field hospitals for intensive care in Sweden, I would have thought it was like science fiction, but it's actually reality today. And we are expecting the worst to come, so we're really preparing for the worst. And we're looking for more protection equipment for hospital staff. It's being rapidly produced and distributed. And as an organization, as being a CEO of a cancer organization in Sweden, I mean, since last week, about 10 10 days ago, we're all working remotely from home. Our office is still open so people can go there and get stuff, but they are not supposed to be there. They're supposed to recommended to work from home. So all our communication, all our meetings are being done remotely, digital. We still try to have business as usual as far as possible, and have sort of done a lot of risk analysis, changed some of our activities, and I'll probably come back to that later. And one of the challenges, of course, is the internal communication and how this will affect us as a cancer organization and cancer patients in Sweden on a long-term basis. We've also, of course, our intranet communication, everything is changed, but the whole country is actually affected, and we're focusing on trying to be extra careful with risk groups, especially elder people from 70 and above, and risk groups, people with cancer, other kind of risk factors.
Thank you, Ulrika. It sounds very similar to the Geneva experience that we have here with UICC. But let me move over to someone who's on the front line of this. Alfredo, you're at the Geneva University's hospital. Tell me about the hospital, what it does, and also, you know, perhaps you could give a thumbnail sketch of what's happening in Switzerland and Geneva particularly.
Yeah. Thank you for first of all, thank you for inviting me and for giving the opportunity to share our initial experience. Our life has been, I would say, dramatically affected during the last probably 7-10 days. We've gone from nothing to a huge crisis, and day by day we really see things evolving. So what has happened is that we have quite rapidly tried to respond to the ramping up number of infected people, unfortunately, coming to the hospital. So as a service and department, I can give you a bit of a heads up about the hospital. So what we're trying to do, this is a big academic hospital. So we have a huge number of patients that come for, I'm talking about cancer patients. So they come from appointment and treatment. So we're working on two different lines. One line was to make sure that all the patients were safe as possible. And to ensure that, we had to try to minimize the number of visits to the hospital. So many patients are getting a blood test done at home, for instance, which is something that we can do. For oral treatment, the patient doesn't come here, but we are delivering the drug for free, of course, to all the patients that live around the Geneva area. We also have changed the schedule of the intravenous drug. There are drugs like immunocheckpoint inhibitors. I don't want to give too much detail about the drug, but anyway, the drug that can be given rather than every 2 or 3 weeks, every 4 or 6 weeks. So we are expanding the time span for the infusion, and therefore we have dramatically reduced the number of appointments. This is on one level. On the other level, we're also trying to ensure that all the health professionals are protect and are safe, and as part of it, of course, is done by the hospital providing PPE and all the masks, and we can't complain at the moment. We haven't had any shortage, any problem so far. Even about all the gel we're using, we haven't had any problem. So I can say that the reaction from our hospital has been excellent. What we also have done, we've done a lot of telehealth. So we are calling patients, we're using webcam as the one I'm using it now. If the patient wants to see us, of course, otherwise we'll just do a standard phone call. And this is working very well. I think patients are very happy not to come to hospital. They're very happy to have just phone calls if possible, unless they're unwell and they need to be seen by us. And we also make sure that some of the team, not all the team, but we split the team in two. Somebody's working from home, somebody's working from hospital. And we have done a sort of rotation. So I'm here today, but I won't be here in hospital, but I won't be in hospital tomorrow. We'll be working from home. Of course, there are limited things as a doctor I can do from home, but I will try to concentrate all the admin stuff, all the phone calls, everything on that day. The other thing we have been doing, and this is perhaps our colleague from Asia can help us here. I'm Italian, I'm not Swiss, as you can probably hear from my thick accent, but having said that, so I have a lot of friends in Italy, and one of the huge debates we have about health professionals is whether they should be tested, whether they should be swabbed, and when they should be swabbed. If we follow the standard guidelines, at least in many European countries, correct me if I'm wrong, even health professionals should not, at the moment when it's the we have a pandemic, where it's pandemic, they should not get tested unless they have symptoms. And those symptoms are defined by fever, cough, but so fever is not 37.5, we're talking about 38.2.5. Now, our service, we had, and this is, I have to acknowledge this and give credit to Professor Didich, who fought for make sure that as soon as we have even a very mild symptom, bit of cough, runny nose, we get tested. An example I want to use is yesterday we had the first positive nurse here in hospital. She has just a runny nose. Runny nose, she was dealing with cancer patient with swab, and she was positive. She's home now. We have isolated all the patients she was in contact with. She was wearing a mask. So we're very confident that it's a very unlikely that she could have passed this to any patient. But I think this is another key point that, you know, we can do whatever we want, but the first thing we need to make sure we isolate people who are positive for this virus. That's the only way to reduce the peak. And this is what we're trying to do in this hospital. And I think my former boss is really fighting hard to make sure we can do that. Those are in principle, there are other things we've done, but I think those are the key aspects we have put in place in the hospital in this service to make sure we can still run a service the best we can and offer the best treatment possible to our patient, exposing them to the minimal risk possible, because this is the other point.
Well, thank you very much for that. I see that we've got our friend Matti Apro is already sending through questions. So we've asked a couple of points, which we'll pick up a bit later. Perhaps we can move over to Korea then. Let's talk to Dr. Choi, because obviously the circumstances are similar but different in other parts of the world. So Dr. Choi, perhaps you could explain to us what the National Cancer Center in Korea is and tell us a little bit about the situation in Korea.
Okay, I'm just going to give you a brief overview. We are the largest solely dedicated to treating and cancer patients. We are a 534-bed institution with 26 ICUs. We're equipped with 12 negative pressure rooms so far. We do clinical therapeutics, transplantation, clinical research, and also cancer prevention in epidemiology and in preventive diagnostics. So that's the just really brief introduction to our organization. The situation in Korea as of today, the today number, we have 99,137 confirmed cases, 126 deaths. The characteristics of Korea is that most of the cases, 84.5% of the cases occurred in the southern province of Daegu and Gyeongbuk. That's about 7,300 cases. And of the 126 deaths, 120 deaths occurred in that region, which you can easily imagine that's where the overflow occurred, and hence more death occurred in those two provinces alone. So in other provinces, only 6 dead, and we have, like in our province, 387 in the Gyeonggi province, where our hospital is situated at, and in our capital city, only 347 cases. So relatively, we're not overloaded, locally overloaded here. So pretty much the situation in our hospital, everything is going as normal. We're not delaying any treatment except for those people who have high risk, like travel or from originating from the Daegu and Gyeongbuk provinces. So except for a selected population of patients, we are doing everything as normally, treatment schedule, surgery, and everything. Yes.
Is there anything else you want to cover, or should we cover it with questions later?
Oh, no. So I'm trying to tell you how we're adapting to this.
Okay.
Yeah. So so far we have, ever since this pandemic started, we started testing for corona since February 20th. It's about one month ago, and we set up tents outside the emergency department to screen for those patients who have suspected symptoms like fever and respiratory symptoms. we started screening for those patients and testing for those patients. And we went through some renovations in our clinic spaces. We separated a part of our outpatient clinic. We put a door and then separate doors, separate entrances, so that the people won't get mixed up with the other outpatient patients. And we started screening every patient that enters the hospital building. We do a survey of whether they have travel history or a fever or respiratory symptoms. That includes not only patients, but also visitors and those accompanying the patients. So virtually everyone who's entering the building. So we do have a little overflow before entering the building, but so that way we can separate the populations that have any suspicious symptoms from those who does not have symptoms. That is one checkpoint. And we are strictly restricting visitors for admission patients. We don't allow visitors currently for any admitted patients, except for on special occasions. That's so limiting the inflow to the hospital is what has changed. So mostly we are focused on prevention. So in selecting those screening, we're focused on screening so far. In Korea, the brief situation is we can do this because we do have almost over 9,000 patients, but in Korea we have institutions designated to treat COVID-19 patients. So far, we have 29 hospitals and 530 beds available, including 198 negative pressure rooms to treat COVID-19 patients, mostly severe patients. They're all university hospitals dispersed in all individual provinces. So we don't belong to those facilities, so we don't get COVID patients transferred. And those hospitals has been increasing their capacity through renovations, continuous renovations during the last month, and I'm sure they have renovated more wards to isolate those COVID patients, to take those patients and transferring ICUs to more negative pressure rooms. So I think these numbers was last December, so it could have changed a lot. However, we are equipped with negative pressure rooms. We are ready to take COVID-19 patients whenever there is a possibility, when, of course, because we expected in like about 10 days ago when we were having like almost 900 patients per new patients per day, we were expecting overflow of these designated hospitals. So we might have to, every hospital in Korea was expected to take COVID-19 patients at any point. So we renovated our ICUs. We got portable negative pressure machines and made more negative pressure rooms. And currently we have 12 so far to take in. And even if we develop COVID-19 patients in our institution, we are ready to take care of those patients.
Okay, well, thank you very much for that. I'm going to move over to Mary Wong. Mary, we spoke yesterday and you were saying that to some extent the experience that you had with SARS many years ago has helped inform the way that your organization and Hong Kong has responded. So first of all, tell us what your organization does and tell us what the situation is in Hong Kong. You just need to unmute before you start. How are we doing? Are we nearly there?
Yeah,
there
I think
you go, Mary, you're online. There you go.
Hey, ladies and gentlemen, good morning or good afternoon, wherever you are. So my organization is the Global Chinese Breast Cancer Organization Alliance. We are not only a patients organization that support breast cancer patients, we are also an alliance of more than 70 Chinese breast cancer groups worldwide. And apart from offering the breast cancer care and support in Hong Kong, where we are registered, we are also a platform for all Chinese breast cancer groups to share, to exchange, and collaborate together. Now, the rapid development of this coronavirus situation, so suddenly, so fast, does represent a very big challenge for all of us. Hong Kong, even though we have about 400 plus cases today, we benefit from the experience that we had SARS 17 years ago. If you remember, 17 years ago, SARS, we were the center of the epidemic. And the fear that we had experienced make us more prepared, I think, for this virus situation. The fear that we had experienced during that time make us more vigilant, more careful, more prepared to, and the citizens are more willing to adopt the measures of social distancing, self-isolation, and avoid gathering, which we have been practicing since end of January, which is more than 2 months now. And actually every gathering, every dinner, party, everything is canceled. Currently, we have no delay in cancer treatment in hospitals, whether it's surgery or chemotherapy or radiotherapy. We are all, it's all going on as usual. And cancer patients are being entering the hospital from another entrance. So it is separated from the main entrance, which is a bit safe for us. The success of the measures we have in Hong Kong, I think the social distancing, isolation, it is because of a lot of people, because of the past experience. So we have a lot of self-discipline. And I think the success depends on a lot on self-discipline. And the lesson that we learned, it helped us a lot. I think that is why, even though we were one of the first cities that had the coronavirus outside China, until today, we do not have community outbreak.
Okay, well, thank you very much for that. Let me pass back to Alfredo. Alfredo, you've heard what's happening in Korea. Anything that resonates with you and what they're doing? Are you doing the same sort of things? Or?
Yes, sort of. So we also have identified different paths for our patient, and particularly what we have tried to do as much as possible. In this hospital, I don't know how it works in another hospital, but in this hospital, if any patient come with a possible, with suspicions of COVID-19, they get tested outside of the hospital. There is a huge tent. The problem is people need to queue, okay? So, and I pretty much understand this. Now it's a bit calm, but last week it was a bit, crazy. So what we're trying to do, we try for our patient. When I say our patient, I mean patient on active treatment to avoid queuing outside. So therefore, we have established, we can call it a COVID clinic, where our patient get access straight away and they get swabbed straight away. If they have mild symptoms, they get back home isolated while we're waiting for the results. And normally the results come back within 20 to 24 hours. If they have symptoms for which we have to admit the patient in hospital, we basically do everything ourselves to make sure that the patient gets admitted in the COVID. We have now COVID positive or possibly positive COVID ward where the patient can admit straight away. So therefore, we're really trying to create specific path for patient on treatment. And of course, the hospital also create a path for patients with suspicious of COVID-19. That's one thing. The other thing we're also trying to do, and I know it might sound silly, but patient come to we are not on the ground floor. We are on the 4th floor. So patient having treatment need to get to the 4th floor, and all of them can run up the stairs. So they get the lift. So we have a lift dedicated to our patient. It's a big one, no more than 2 patients at the time. Which I know all small things that if we wouldn't even think about in a normal life, but it needs to be put in place at the moment. We are working, and this is one of the questions I also would like to ask to other panel members, but we're working to have, and I'm strongly in favor of these, a thermal scanner at the entrance of the hospital. So whoever wants to get in needs to have his her temperature checked before coming in. We don't have that yet. We're working on it, and I'm very much hoping we're going to get it at some point, because I think there will be an easy tool to screen people. I won't say even patient people, could be health professionals, could be anybody coming in.
We heard from Dr. Choi that they've stopped visitors coming in. So
that's
maybe
another thing we have.
Dr. Choi, I mean, in terms of testing individuals before they come into the then you said into the hospital, you said that they were checked in some way. Has that proved to be successful, do you think?
Oh, sorry. Can I only add one thing before? The only thing I want to add, when we also have done this, we've reduced the number of visitors for patients, but we need to bear in mind we have people at end of life. Right. So it's pretty much tough to say, oh, it's we're going to expose to the, we do have to do it. It's sensible to do it, but we need to compromise given the situation. COVID is a serious stuff, undeniable. But there are people dying from cancer that deserve to die with their relatives, surrounding them. And this is something we need to all work together to ensure.
Yes. At the entrance gate, we screen, we have a survey. We have a paper survey. And every day, I think the people who say they have travel history or respiratory or fever, febrile symptoms, or anything of kind, about like 100 people a day who say yes. So those are the people who come to the, as you put it, the COVID clinic. We have a separate part of the outpatient clinic. We built walls, and we have dedicated elevators connecting to the transitory ward if they need to get admitted. That's how we have it set it up. In the patient clinic, we simultaneously do swabbing and then an X-ray at the same time. So we can at least check out people who has pneumonia, and then we can admit those patients right away. Also at ER, we also have another checkpoint in front of the ER, and we screen for those patients in front of the ER. And those patients, the patients who visit the ER department usually have pending symptoms that need admissions. So we screen for those patients. If they have fever or respiratory symptoms, we also swab them right away and then send to the ward. The negative pressure rooms I told you about, we had 12, but actually we can, 8 is situated on the 3rd floor, which used to be the MICU. We closed down the MICU and solely using it for a transitory ward for possible COVID patients. So far we didn't have any, so we're using it as a transitory ward. It takes about 12 hours for us to get the results once we swab the patient. So if the patient turns out negative, then we just send them up to the ward and then empty that place to take other patients. So we don't have patients clogging there. In regard to visitors, like you said, of course, there are visitors for many purposes, like for people just to a friendly visit to those of end of life. So we've been doing this for like almost a month and a half, the screening. It really takes massive labor. We've got many gates, and we have 3 to 4 people at each gate with thermometers checking everyone entering the building. We do have a thermal camera at the main gate, but we also do individual checking for each people. And we stratify visitors depending on what their purpose of the visit is. People in the ICU, people in this surgery, people for end of life. Of course, we cannot prohibit those people from coming in, so we check them thoroughly. And then we give them visitor tags. That's how we manage them. So it's really labor taking, but I think when we do this, the patients, they really have this sense of security. Yeah, so they feel safe. So it's good. We do have some trouble with visitors. Why not? Why can't I come in? Those quarrels, but that's really a minor part of this whole process. But I think the patients, they actually feel really safe. They're getting treatment in a safe environment. Yeah,
that's an important point. I mean, we've heard from Geneva and yourselves about treating patients. I mean, Ulrika, if I come back to you, I mean, I understand your organization doesn't treat patients, but you provide patient support and advice and guidance. So how has your operating model changed as a result of coronavirus? Are you changing deliberately, or are you finding that your clients, the patients or others, are demanding more from you?
Both. We've actually changed deliberately, and actually in 4 areas, I'd say. The first, of course, was to provide patient support and guidance to patient and next to kins. So we provided guidance and sort of accurate information on our website to cancer patient and their next to kins. And then we have a helpline staffed with nurses, where people can address the helpline through phone, emails, and also we have a chat function. And today, 99% of the questions coming to the helpline is related to COVID and cancer. So we have all the most frequently answered questions. We provide them on our website, but also we have the helpline open much more hours, more staffed. So we increased the number of staff and also increased the ways people can have access to this helpline. And also to give guidance to other patient organizations in Sweden. But we're also now starting to work in other areas, looking deeper into the long-term effects, since cancer patient treatment is being postponed, and if screening activities is also being postponed, what will that be in terms of long-term effects for cancer patients in 6 months from now, 12 months, 18 months from now? So we have the information, we know, so we won't go back in time when things go back to normal. It won't be like normal 5 years ago. It will be a new normal when we know what kind of work we need to do to support cancer patients. And the third area we're now starting to look into now, it might sound a bit odd, but it's actually also about the long-term effects. We're looking into areas where we can now start exploring evidence for stronger advocacy messages, looking into COVID and smoking. We're doing a systematic review of the evidence. We've started collaboration with the public health authorities to further investigate this and whether there should be stronger recommendations regarding smoking. Not now, probably not in 3 months, but maybe in a year or something. So we need to start gathering the evidence and looking into the research that's been done so far. But the fourth area we actually have to look into is fundraising. It must sound a bit odd, but since we're the biggest fundraising organization in Sweden and we fund research, we don't want to risk that cancer research isn't funded in the future. So we are looking to, and since so many companies in Sweden are affected, we're looking especially at the small partners we have, if we can reduce their fee, not to lose them as partners, but could they have some kind of reduced fee to keep them as partners for a longer term. And we're also looking into new ways of working with some of our partners. One of our partners is the main leading grocery retailer in Sweden. And could they assist cancer patients by delivering their groceries to their homes instead of them risking to go to get their own grocery, for example. And we're also changing and converting our retail campaigns to online campaigns, preparing now for the Pink Ribbon campaign in October. We can't have that as a continue as usual, having that as a normal retail campaign, but prepare to have it online. And of course, we have a digital strategy, but we need to stress the change even more. And looking at the public donations, it's too early to see that if they are going down, but they probably will when economy will change. And we need to adapt our communication as well. So we've adapted our messaging, not to sound opportunistic by providing corona-related messages, but to be more, have the tone that is quite sensible right now, and also be a source of facts, not speculations, and but to be the sort of the source of facts. and to have updated information all the time. And our PR team, they are also adapting to the new landscape, looking at more working with long-term, long lead media, and not going into short-term, because we're in a corona shadow now, but preparing for some kind of COVID cancer-related messages, but not making it sound opportunistic. But so in terms of services, changing more with the helpline to provide support to cancer patients, looking at the long-term effects for cancer patients when their treatment is being postponed, looking at, from a long-term perspective, changes in advocacy messages concerning the evidence on smoking and corona, and really start changing our fundraising activities. So some are deliberate, some are forced on us.
Ulrika, I think you echoed the concerns and thoughts of many cancer organizations around the world, and it's important that you do touch on the issue of fundraising, because we rely on the money to do the research, to do the support, to help patients, to inform our advocacy agenda and everything. So it's an important point that no, we shouldn't run away from, that the financial challenges of the next 12 months are going to be difficult for everyone. Mary, perhaps I could come back to you to ask you how you've changed your operating model in terms of working with your patients across China and elsewhere, and has it forced you to rethink how you deliver your services? Mary, you need to come up. Oh, you're okay now.
I'm okay?
Yeah, you're okay.
Indeed, we can no more carry on the traditional ways of supporting our patient face-to-face via support groups and all that. We have to change very fast to do it with social media, which is actually a very big challenge for all of us, because cancer patients still undergoes all the treatments, and cancers are still being diagnosed every day. And in Hong Kong, cancer treatments still continue is without stop. However, if you are going to a hospital for surgery, in Hong Kong, you're not allowed to be visited by your family. So you are totally isolated in the hospital. So actually, cancer patients are very scared, and they are very anxious, because apart from their own illness, they are also anxious that they are in a hospital, whether they would catch coronavirus. And it's the fear that is making them depressed, and the isolation is making them very worried. And that is why we have to change the model. And actually, in early March, we have launched what we call a three-pronged approach via the social media. So the first one is we have a telephone hotline, which we call the 789 telephone line, which is 7 days a week, from 8 o'clock in the morning to 9 o'clock in the evening. So patients can call in and ask whatever questions or anxiety or whatever they have, they can talk to us. And the second one we have is an emotional e-support, which is via WhatsApp. We form many small groups, about 500 small groups. Each small group has a mediator, a survivor, and the patients, and they can discuss what their fear is, and how they can help each other. And once a week, we have a Zoom session, so that a larger group can be together and they can share their experience, exchange information, how to cope with the situation, the strategies they adopt, and guided by medical professional. And the third one we have is a Facebook Live session, dialogue with experts. That's very important, because in this situation, so the patient at home, they can talk to the doctors and medical experts about their condition, about how to cope with the virus and cancer treatment at the same time. And also caregiver can get help, can know what to do. And this Facebook Live actually is very important, actually very popular indeed, because we have, the last one we have is about 3,000 people attended. And it gives us because Facebook Live, we can have many people, rather than Zoom, we are limited to 100 or something. And people can give live questions in also. And apart from that, we put on YouTube all kind of exercise for relaxations, for what you can do during this time, because in Hong Kong, we are isolated, everybody is isolated at home, and actually it's very depressing. So exercise can help us to relax, to think of something else rather than, only the illness. And also we try to deliver a lot of positive messages through the online, the digital means, and every day, every week, we put out new messages for all our patients to encourage them that this is not the end of the world.
Well, that's tremendous. And I think we're fortunate in these rather difficult times that we have so many social media outlets and the ability to reach people in their home. If you go back 15 years ago, probably when SARS was around, there was no social media, there was no Facebook, there was no anything at all. So I guess to some extent we're fortunate that the world has moved on and we can reach people into their home. The fact that I'm sitting in my home in an office and talking to you around the world is an extraordinary facility for discussing how we address this particular challenge. Alfredo and maybe Dr. Choi, just a question for you. One of our dear friends, Marika Leafy, who must be up extraordinarily early in the morning because she's in Brazil, sent a note about the experience of the rate of positive COVID-19 test results using temperature screening. How successful do you think that is in terms of making decisions on people coming in or having the illness, the virus? Alfredo, what's your view on that one?
I mean, I can only, of course, give my personal opinion as we have no data whatsoever. So I'm not sure that would be really effective, frankly. But I think it would be a way to do a very easy screening and make sure nobody with fever comes in. Then many people might have fever. We have the few people tested with fever. They of course, they were negative. They had, the flu or something similar. So I cannot share any figure, but I would imagine it would be a very simple way. And this is what we're seeing. We're seeing data coming out every day, and maybe in a month, 6 weeks, we might go out with something and say, look, it's useless, forget it, it's nonsense. But until then, I would be strongly in favor of at least trying something extremely simple and see whether you can increase the number of people you identify straight away.
Thanks. Dr. Choi, you mentioned earlier that this often is more of a giving comfort as well to the visitors and to the patients, that you are being cautious and sensible. Is that what you're finding?
No, that's actually a byproduct. Of course, patients feel safe because we do it, but we're not doing it to make them safe. We're actually doing it for our safety. In Korea, as you all know, in 2015, like MERS, the institutional mortality rate reached about 30 or 40%, depending on institutions they were hit. So whenever a patient occurred in that institution, we closed down. The city closes down the institution. So we do have the risk of that, and practical risk of if a patient develops, considering this high infectivity, and if the cancer patients really catch corona, the mortality rates will not be what we see in the community, much higher. So it's an actual risk that we're fighting with. So far, I think we only tested about a couple hundred, but in Korea overall, the positive rates are like, what, 3.4% overall? About 35, 350K, 350,000 tested, and then we have about 9,000 patients that would about reach 3% positivity in overall tests. So 97% of the patients we test would come negative. We do very, very many screen tests. And I think we do, not only us, but also other institutions do screening to find, just to confirm negative on all those patients who come with fever and respiratory symptoms. But I do think that's what made it, even if we find like one patient in 1,000 tests, it would still have meaning. That's what we're doing, early detection, just isolate whoever we find positive and then segregate them from the population. It's really, really labor taking, but I think that's what actually made it possible for us to flatten the curve right now. Yeah.
It sounds like that was successful. Let me just pass the question over to you, Ulrika. Oh, sorry. Please.
No, I want to just to reinforce what Dr. Choi says. That what you want, and you don't want to see what happened in some Italian hospitals. So basically, you want to make sure that you catch the possible positive patient as soon as possible, because as soon as you hang around a bit for the hospital, then it's a nightmare to isolate all the people and get in contact with them. So I think that is definitely the way forward. Sorry, thank you very much for sharing.
I think, you know, this is, I'm amazed as someone who doesn't work in a hospital, how much lengths you've gone to protect patients, to protect yourselves. I think it's absolutely important. I'm conscious that Matti Apro was quick off the mark this morning with some questions. As ever, Matti's there straight away. So Ulrika, a question that Matti's raised is he's been contacted by people who've had cancer in the past, wondering whether they are high risk now, even though they haven't got cancer. And are you seeing that in Sweden? Do you see that the ex-cancer patients are concerned about their health?
Yes, definitely. And that's the kind of questions we get to our helpline, and we provide them with expert answers. And what we say right now actually is if you've had cancer, been treated 5 years ago, and from now and back to 5 years ago, you are more at risk. So you should really be social distancing a lot more than we should all do actually. So we're looking into the latest facts, giving that kind of advice through our helpline and on our website. And we get a lot of anxious and worried questions. So, and it's a balance. We try to balance not to worry cancer or former cancer patients even more, to try and make them sort of more to be sort of fact-based and still calm them down, and say try to give them the information they can actually use and how they can actually do something themselves by social distancing and by being aware of symptoms, but not be even more afraid. And of course you are worried when you've had cancer or have people with cancer in your family.
Yeah, I'm sure, Mary, I guess you're taking questions from ex-cancer patients as well, being concerned about whether they're high risk. Is that true?
We have a lot of questions from cancer patients concerning about whether they are more at risk. Yes, actually, we have, that's why we have this Facebook Live with experts, so that they can directly get the answers from experts about how to protect themselves, how to what they should do in such situation.
Okay, well, I would love to take more questions, and thank you everyone who submitted questions before and today, but we really need to move on to the last 10 minutes or so. What I'm going to do is I'm going to ask each of the panelists to give us, from their perspective, what advice they'd give to UIC members around the world. And I think this panel sort of reflects the nature of the membership of UIC. We have over 1,200 organizations who are members of UIC in 170 countries. They are patient groups, cancer societies, they are hospitals, they are, you know, research centers. We've got a full gambit of organizations, and everyone is affected differently by the same problem. So it would be useful, I think, if each of the panelists could say, like, now, what's one thing to really keep in mind that we've learned so far, which you as an organization should plan into your thinking for the next few months. And if you could just think about those countries where the coronavirus has just begun, because some of us are, you know, 1 month, 2 months into it, and you know, we can see the impact over a few weeks. It was only a month ago that we had the first coronavirus patient in Switzerland, and today the country is shut down. It was 1 month and 2 days ago, I think it was. Alfredo, let's start with you, Alfredo. What piece of advice would you give to UIC members around the world?
My advice is very simple. Act quick, and act heavily and strong. I think many people, when I was concerned about the data I was seeing from Asia and also from Italy, many people were trying, oh, you are a fearmonger. I don't think I was. So I think you need to plan things in advance. And as you can see, because if you wait too long, it might be not too late, but you might have a lot of repercussion. So try to act as quick as possible. I think the key, I hear a lot of people concerning about ITU beds. Yeah, it is important. Sure, yeah. But if you base your strategy just on increasing the number of ventilators in an ITU bed, then you might fail miserably. What you need to avoid the spread. You need to make sure that, particularly in hospital, you're able to isolate the person, the people that come in mildly symptomatic with this virus at the entrance. As soon as the virus is in the hospital, it's a disaster, even if you have 2,000 ITU or ICU beds. And that would be my message. Act soon and quick and act strong. There was a paper very interesting say, hammer and dance. And that's what we have to do. We need to hammer on the head and dance with it.
Well, that's great advice. And I guess that applies to individuals, organizations, and actually countries themselves as well. Ulrika, what about yourself? You mentioned a couple of things earlier, which I think are very important to our membership. Any advice from you for UICC members, what they should be doing now?
Yeah, it sounds very boring, but start now to look into the financial impact and the ability to raise money for your organization and secure as many of your partners as possible. Get a grip of your reserves to understand for how long you can actually go on with your business with limited or maybe no income for a certain period, and rethink your fundraising campaigns and move into digital fundraising. Rethink some of your communication activities. We need to adapt to the dramatically changing context, because your partners, they will rethink their partnership, your partnership, and the public, they will respond to different kind of messaging. So really look into how you can secure your funding to be able to actually do the work you're doing. And work with your neighboring countries. I mean, I'm so happy that we live in the Nordic, that we have a strong collaboration with our Nordic colleagues, sharing information, learning from each other. That means we have to do less work on our own, and we can actually build on what's being done in other countries and in other cancer societies within the Nordic group. So I'm really happy about sort of getting it together with my colleagues in other countries. But look at without money, we can't do anything.
Well, we've had a question in from Leo Canadilla from Spain on the issue of, forecasting donations and keeping going. I mean, those organizations rely on public donations are probably going to struggle a lot in the next 12 months. It won't be the next 3 months, it will be longer. So I think your advice is certainly should be listened to by many organizations. We don't want cancer organizations to go out of business because of this. We want them to grow, develop, and have an impact in the longer term. And I think from a UIC perspective, we will be focusing our efforts in the next 6 to 9 months to help cancer organizations through this crisis, because we really do want this crisis not to be the end of a lot of cancer advocacy, support, and patient support. Let's move on to Mary. Mary, you've been through SARS and you're now going through coronavirus. So what's your advice to UIC members around the world? What would you say that they really need to do in the next couple of months?
I think we should all keep a close eye, stay aware of the latest information on the coronavirus outbreak, stay ready to adjust and change our service model to cope with this new situation. Actually, many cancer patients are telling us that they're very scared, they're very anxious and depressed. There's too much unknown ahead of them because of the present situation. And on top of that, there's too many daily negative and depressive news about the virus spreading around us that makes the cancer patient more anxious. The figure growing up in tens and thousands every day are very scary. And all the more during this time, I think we should reach out to the cancer patients to assure them that they are not alone. A phone call, a hello, a WhatsApp message, a heartwarming message, a positive information amidst all these negative things on how to cope during this extraordinary time, online chat group, an assurance that help is always there and that they are not alone. We are still there to help them, and that someone is out there for them is very important. And I think that this will help us a lot to create hope. I think we need to have hope during this difficult time. And I think that the global community can help a lot to share information and maybe to help smaller patients groups, because actually I have come across that many smaller patients groups, they have difficulty to change to the digital model of patient support or the social media patient supports, because many of them are not familiar with this type of things. And because of that, they become dormant, and which is very difficult, is not good for the patients. And if we can have more help to them, that would be nice, so that we can multiply our effort to support cancer patients.
Thank you very much. That's excellent. And perhaps I could just go on to Dr. Choi. Dr. Choi, any advice for UICC members around the world, cancer organizations who probably have not had the experience you've had so far?
Yes. Okay. So I think we can, what I like to say is on two aspects. One is on an individual institutional level. Like I told you before how we do it, we need strict entrance screening for all suspected symptoms with risk factors, demographics. And at the governmental level, distributing resources, notifying other institutions who are, I think it's important to designate institutions that has the ability to care for these patients at an early phase. Those countries who are not affected so far, who still have time to prepare for this. Korea, back in 2015, we really had this traumatic experience with MERS. So after that, the Korea CDC set up an emergency situation center, which gets control of all the available resources in the country and all the national university hospitals. They made us make negative pressure rooms, wards to isolate these infectious patients in case of this kind of pandemic. So at a very early phase, we did have patients, but they were put into those designated institutions. So the other hospitals didn't have to really panic of these patients running into their hospitals without being ready. So we kind of had a buffer phase for that, and we still do. And instead, what our institution does is take those patients from other hospitals who have been transferred out of those hospitals because they were taking corona patients. So I think it's the role playing for those with corona patients, those without. I think that's important to stop the panic in the first phase, and then more effective utilization of healthcare resources, most of all, and to prevent contamination by mixture of COVID patients, not COVID patients, especially with lack of those protective gears, would really lead to explosive numbers of nosocomial corona patients. So I think those who still have time really need to work on that.
Dr. Choi, thank you very much. I've got my 2-minute warnings, so let me try and summarize what has been a fantastic panel. And can I first of all thank the panel for taking the time to dial into this webinar to help UICC members and others around the world. Everything you've said, I'm sure, has been noted down, and it will be used to inform others around the world. Let me just pull some key points that I thought come across. Act quickly and learn from others who are ahead of you. Absolutely critical. Screening and separation, making sure that you can keep the virus under control in hospitals, particularly cancer centers. Also, I love the idea of share information, make sure it's good information that you're sharing, well evidence, and try and quash some of the fiction which is running around the community at the moment. And let's reach out to cancer patients who have the double burden of fear that they have cancer, and they also potentially could get coronavirus through their treatment, or they're more likely to die if they do have coronavirus. Let's wrap our arms around everyone with cancer at the moment to make sure they feel comforted and cared for. Ulrika, critical point, we've got to look after everyone else, but we have to look after our organizations. We have to sustain ourselves through this economically challenged time where fundraising will be more difficult. And we also have to probably campaign with some sensitivity to the current crisis with governments to make sure that they still see cancer as being an important disease that will not go away in 2, 3, 4, 5 years' time. It's still going to be around, and we want to be around to campaign on behalf of the patients altogether. If I could just quote Mary and say, we have to create hope. All right, create hope across the community. This is a difficult time for us all, but if we do the right thing, learn from each other, share best practice, stay together and work on behalf of cancer patients around the world, then I do believe we will create hope. So thank you very much to everyone who's been on the panels. Thank you very much for those who've dialed in. And as I said at the beginning, UICC will seek to run a number of these webinars over the next few months to keep you up to date and informed. We will make a copy of this, a recording of this available, but only for a week, because as Alfredo pointed out yesterday, probably everything we say today is out of date in a week. So we'll try to update the information as soon as we can and share it with our community around the world. I wish you all health, and I hope that the next few months are as safe as they possibly can be for everyone. Thank you very much.
Thank you. It's been a pleasure. Have a good day.
Thank you. Good day, everyone.
Bye-bye.